Finishing out the Unit 3 lecture, we're going to continue on with the formed elements in the urine sediment. So picking up at casts. Casts are the only element found in the urinary sediment that are unique to the kidney. So they're formed in the distal convoluted tubule and the collecting duct, so they can provide an indication of the conditions within the nephron at the time that they were formed. It's essential to view them under low light because the matrix of the cast, which is kind of it's kind of like the shell, has a very low refractive index. The cast matrix will dissolve quickly in dilute alkaline urine, so it's important, as always, to get a fresh specimen. The cast composition and formation. The presence of casts is associated with underlying renal conditions. The major protein that casts are made of is uromodulin, aka TAM horsefall protein, which we've mentioned previously, and other proteins such as immunoglobulin and albumin are also found in the cast matrix. Excretion of TAM horsefall occurs at a pretty constant rate and seems to increase during periods of stress and exercise. Formation of casts occurs more readily during urine stasis in an acid pH and when there are increased levels of sodium and calcium present. And TAM horsefall is not detected by the reagent strip because the strips, if you remember, we mentioned previously, are most sensitive to albumin. Formation of the cast occurs when TAM horsefall accumulates and attaches to the renal tubular epithelials. The protein begins to interweave and forms that matrix. It traps elements at the same time. The cast detaches from the RTE and then the cast is excreted. The width of the cast depends on the size of the tubule that it is formed in and also by the materials present in the filtrate at the time of formation and the amount of time that it was allowed to remain in the tubule during formation. Casts that form in the junction of the ascending loop of Henle and the distal convoluted tubule may produce structures with a tapered end that are referred to as cylindroids. These have the same significance as other casts. Okay, your hyaline cast, this is the most commonly seen urinary cast made up almost entirely of TAM horsefall protein, and the presence of 0 to 2 per low power field is considered normal. They can be seen in increased numbers following strenuous exercise, dehydration, heat exposure, and emotional stress. Pathologically, they are seen in acute glomerulonephritis, pyelonephritis, chronic renal disease, and congestive heart failure. They have a very low refractive index and can be easily overlooked if they are not viewed on low light. Phase microscopy and Sternheimer-Malbin stain can be helpful in observing them. And they can come in several different forms, including parallel sides with rounded ends, which is going to be the most common form, cylindroid forms, and wrinkled or convoluted forms that indicate an older cast. Here's a couple other pictures of hyaline casts and just maybe some different forms. And in this one, you can see how, especially compared to what looks like yeast and white cells, just how low that refractive index is and how it really tends to kind of blend into the background. Red cell casts. So red cell casts specifically indicate bleeding within the nephron and are associated with damage to the glomerulus and is also usually seen in conjunction with proteinuria and dysmorphic red cells. They can also be seen in healthy individuals following strenuous activity. They have to be observed under low light and they're going to have kind of an orange-red color. They are going to be more fragile than other casts, and this is exhibited by the fact that they are more commonly present in fragments and will have a more irregular shape. As the cast ages, it will become more uniform as the cells lyse, but they will still retain that kind of orange-red color. It's important to correlate the presence of a possible red cell cast with the reagent strip results and the presence of red cells in the microscopic exam, because it's highly unlikely that red cell casts would be present without the other. So you would not expect to see a red cell cast if your reagent strip is not positive for blood, or you're not seeing individual red cells. If excessive hemoglobinuria or myoglobinuria is present, you will see more uniform casts that are more of a granular dirty brown. This version of the red cell cast is associated more with tubular necrosis that comes from massive hemoglobinuria and can lead to renal failure. And again, here are just some more variations on those casts. Okay, talking about white cell casts. White cell casts indicate an infection or inflammation within the nephron. They can be seen in bacterial infections such as pyelonephritis, which are located in the upper UTI, and cystitis, which is lower UTI, where there will also be bacteria present in the specimen, but they are also present in non-bacterial inflammations such as acute interstitial nephritis, where no bacteria will be seen. They can be seen along with red cell casts in cases of glomerulonephritis. Neutrophils are the main type of white cell that make up white blood cell casts and will appear granular and possibly multi-lobed nuclei if the cast hasn't degraded too much. Supravital staining can help differentiate white cell casts from renal tubular epithelial casts. Bacterial casts can resemble granular casts because the cast can be so packed with bacteria. It can be confirmed by doing a gram stain. These can be seen in cases of pyelonephritis. The bacteria can be contained within the cast and bound to the matrix and can also be mixed with white cells. And it's important to correlate the potential presence of bacterial casts with white cell casts and free white cells, which would be further indication of an infection. Okay, your epithelial or renal tubular cell casts represent advanced tubular destruction that produces urinary stasis in addition to disruption of the linings of the tubules. It's associated with heavy metal and chemical or drug-induced toxicity, viral infections, and allograft rejection, and they are produced in the distal convoluted tubule. In cases of pyelonephritis, they can be seen in conjunction with white cell casts. In these casts, while some of the cells may be seen within the cast, the majority of the cells will be seen on the matrix or on the surface of the cast. These cells are smaller and can be round or oval and can be confused with white cells. So they can be differentiated with staining or with phase microscopy. Next are your fatty casts. These would be seen in disorders causing lipiduria. These casts will be seen in conjunction with oval fat bodies and free fat droplets, commonly associated with nephrotic syndrome, but can also be seen in toxic tubular necrosis, diabetes mellitus, and crush injuries. These are going to be very refractile. The cast matrix can contain fat droplets and oval fat bodies. Confirmation of these casts can be made with a polarized scope and your lipid stains, so either Sudan 3 or oil red O. Granular casts can be either finely or coarsely granular, but it is not necessary to distinguish between them. These casts can also be present in pathologic or non-pathologic conditions. In non-pathologic conditions, the granules originate from the lysosomes, which are organelles that contain digestive enzymes that are excreted from the renal tubular epithelial cells during normal metabolism. These can be seen after strenuous exercise. Pathologically, granules can represent disintegration of cellular casts and tubule cells or protein aggregates that have been filtered by the glomerulus. If the granules are present as the product of cellular disintegration, then it represents urinary stasis that has allowed the casts to remain in the tubules, and these casts may occasionally contain a recognizable cell. They can easily be mistaken with clumps of crystals or fecal debris, so they have to be viewed under high power in order to determine the presence of a matrix. And it also may be necessary to use stain in order to see some of that nuclear detail. Granular casts further disintegrate to form waxy casts, which is our next one. Waxy casts are representative of extreme urinary stasis, indicating chronic renal failure. They form from the disintegration of granular and hyaline casts, and as they degrade, the matrix takes on a waxy appearance. They become wider, the ends can become jagged, broken, and they're more brittle. These are highly refractile, so they're much easier to see under bright field than hyaline casts are. However, if you have to stain, they're going to stain dark pink with your supravital stain. Broad casts are sometimes referred to as renal failure casts because they represent extreme urine stasis. As they are stuck in the distal convoluted tubule, they form a mold of the tubule and become wider, which represents the destruction of those tubular walls. Any type of cast can be a broad cast, though most commonly seen are going to be the granular and waxy casts, since they are more associated with urinary stasis. In cases of tubular necrosis caused by viral hepatitis, there can be bile-stained broad waxy casts. Okay, and then finally, the mixed cellular casts. Sometimes you can encounter the presence of more than one element in a cast, which makes identification more difficult, though a primary means of identification is to look for other homogeneous casts of at least one of the cell types. Examples of some mixed cellular casts that can be seen include red cell and white cell casts, which can be seen in cases of glomerulonephritis, white cell and RTE cell casts, or white cell casts and bacterial casts, which can be seen in cases of pyelonephritis. Okay, the next section that we're going to get into are urinary crystals, and those get divided in between clinically significant and non-clinically significant crystals. So most of the crystals found in the urine are not clinically significant, but they would still be reported. The crystals that are clinically significant are associated with disorders such as liver disease, inborn errors of metabolism, or renal damage caused by the crystallization of medications in the tubules. So that would be referred to as iatrogenic. They can take on geometric forms or amorphous forms, and they're going to get reported as rare, few, moderate, many, or as 1+, 2+, etc., depending on your lab's criteria. So crystal formation, they are formed when urine solutes, such as inorganic salts, organic compounds, and medications precipitate in the urine. This precipitation of these compounds is affected by temperature, the concentration of the solute, so how much of it is present in the sample, and the pH of the sample. Low temperatures will precipitate the solutes faster, so the formation of crystals takes place more readily in specimens that have either been refrigerated or remained at room temperature for extended periods. Because of the increase in formation, the crystals can obscure other elements present in the specimen. So when the number of solutes in the urine reaches a certain amount, they are not able to remain in solution anymore and will start to form crystals. So the presence of crystals in fresh urine will usually also accompany a very high specific gravity. And as we've talked about before, pH plays a large part in the types of crystals that can form in the urine, so that the pH becomes a determining factor in the identification of the types of crystals that are present. So if you are looking at a crystal in your microscopic exam and you think it's, I think it's this type of crystal, only certain crystals can form in certain pHs. So if the pH of that specimen is not right for that crystal, then you can rule it out. Generally speaking, organic and iatrogenic, which again, iatrogenic just means that it's something caused by treatment. So your organic and iatrogenic compounds will form crystals in acidic urines, and inorganic salts are less soluble in neutral and alkaline urines. One exception to this rule is calcium oxalate crystals, which is capable of crystal formation in acidic and neutral urines. Okay, so just some general identification techniques. Most of the crystals that you will see in urines will have distinct characteristics, but some variations can exist, which can make some of the significant crystals hard to distinguish from some of the non-significant crystals. The first thing to do, again, check that pH. All abnormal crystals are found in acidic urine. Other factors that are useful for determining the identification of a crystal are polarization characteristics when viewed with polarized microscopy and the solubility characteristics of the crystal. For instance, when a specimen that has been refrigerated is warmed, any amorphous urates that have formed will dissolve, but conversely, amorphous phosphates have to have acetic acid in order to dissolve. But that's not a practical solution because then it would also destroy red cells and some other formed elements. So if it gets to that point where solubility characteristics have to be determined in order to identify the crystals, then you would want to use an aliquot to pour off for testing. Okay, so now getting into the different types of urine. So normal crystals in acid urine. So again, these are going to be broken up between acid and alkaline. So we're talking about the crystals as they relate to the pH of the urine. So some of the normal crystals in acid urine are amorphous urates, uric acid, and calcium oxalate. Most common crystals in acid urine are the urates. So again, that includes the amorphous urates, uric acid, and sodium urates. These are the only normal crystals found in acid urine that appear colored. So they're going to have a yellow to brownish red tint when viewed under the microscope. In the urine sediment, though, they will appear pink due to the pigment uroerythrin that accumulates on the surface of the granules of the crystals. Okay, first talking about amorphous urates. They can be yellowish brown and granular. Most of the time they're going to be seen in clumps and can be confused with granular casts if you're not careful. So you have to look for the presence or absence of a matrix. Amorphous urates will only appear in acid urines with a pH greater than 5.5, which is not true for uric acid crystals, which can appear in urines with a pH less than 5.5. Okay, and then your uric acid crystals, these can come in several different shapes, including rhombic, which is a parallelogram, four-sided flat plates known as whetstones, wedges, and rosettes. They can also appear in a six-sided shape similar to cystine crystals, but uric acids are highly birefringent and can be distinguished by this feature with the use of polarized light, which you can see in the image here. They can be colorless, but they are normally kind of a yellow-brown. Increased numbers of uric acid crystals are associated with increased levels of purines and nucleic acids. Leukemia patients undergoing chemotherapy, patients with Lesch-9 syndrome, which is an inherited disorder caused by an enzyme deficiency that causes a buildup of uric acid crystals in all body fluids. The patient would have neurological effects, including intellectual disability. And then you can occasionally see these crystals in patients with gout. Okay, the next one is calcium oxalate. Although they are mostly seen in acid urine, they can also be seen in neutral and rarely in alkaline urine. The most common morphological form is the dihydrate form that is colorless and looks like two pyramids or like an envelope, like you see here. The rarer form is the monohydrate form that are oval or look like a dumbbell. This form is seen with ethylene glycol poisoning, in which large amounts of these crystals would be seen. Ethylene glycol is antifreeze. So if a patient comes into, for instance, a patient comes into the emergency department and the doctor was to suspect antifreeze poisoning, he or she could order a urinalysis, and presence of these would be indicative of antifreeze poisoning. Both morphologic forms are birefringent under polarized light, and clumps of calcium oxalate crystals in fresh urine are associated with formation of renal calculi or stones. Okay, the next group of crystals that we're going to talk about are the normal crystals in alkaline urine. So in alkaline urine, phosphates make up the majority of the crystals seen, including your amorphous phosphates, triple phosphate, and calcium phosphate. Other normal crystals that can be found in alkaline urine include the calcium carbonate and ammonium biurate. The amorphous phosphates are similar to the urates in that they are granular and often appear in clumps, though the phosphates will cause a white precipitant in a refrigerated specimen instead of a pink, and phosphates will not dissolve when warmed. Your triple phosphates are known to have a characteristic, what they refer to as coffin lid shape, and as they disintegrate, they may become feathered at the edges. They're birefringent under polarized light. Even though they have no clinical significance themselves, they are often seen in highly alkaline urines associated with the presence of urea splitting bacteria. Next is calcium phosphate, which are not commonly seen. They are colorless, flat, rectangular plates, or they can also be thin prisms, often in rosette formations. When they are in the rosette formation, they can be confused with sulfonamide crystals if they are seen in a urine with a neutral pH, but calcium phosphate will dissolve in dilute acetic acid, whereas your sulfonamides would not. They are not clinically significant, though they are commonly found as a constituent of renal calculi. Calcium carbonate are small and colorless with dumbbell or spherical shapes. They can be seen in clumps that can resemble amorphous, but they can be distinguished with acetic acid because they produce gas when it is added. They are birefringent and they are not clinically significant. And then your ammonium biurate crystals are yellow-brown. They are referred to as thorny apples because they are spheres surrounded by spicules. They are the only urates that are found in alkaline urine, and like the urates, they will dissolve at 60 degrees Celsius. They're not clinically significant and are almost always seen in old urines as a byproduct of urea splitting bacteria. Okay, now we are going to get into the abnormal crystals. So the abnormal crystals are found in acidic urine and very rarely in neutral urine. Most of the abnormal crystals are going to have very characteristic shapes, but it usually takes other patient information, including known disorders and medications, to identify the crystals. When the iatrogenic compounds precipitate in the renal tubules is when the crystals can be considered clinically significant. First one is cysteine crystals. It's found in the urine of people who inherit a metabolic disorder that prevents them from being able to reabsorb cysteine into the renal tubules. These people tend to form renal calculi from an early age, so usually you'll see onset in the teenage years. They're colorless hexagonal plates that may be thick or thin. You can see disintegrated forms when ammonia is present. It can be hard to differentiate from uric acid crystals, but uric acid crystals are very birefringent, whereas only the thick cysteine crystals will polarize. And the cyanide nitroprusside test can be used for confirmation of cysteine crystals. Next is cholesterol crystals. Due to the fact that lipids remain in droplet form, cholesterol crystals are almost never seen unless specimens have been refrigerated. They have a very characteristic shape, so it's a rectangular shape with a notch in one or more of the corners of the crystal. So on the image in the screen here, you can just kind of see that little notch that's taken out of the corner there, and kind of down here also. They're seen in disorders that produce lipiduria, such as nephrotic syndrome, and they are normally seen along with fatty casts and oval fat bodies. They are highly birefringent under polarized light and can be confused with the crystals formed as the result of radiographic dye media because they are also birefringent. So you have to differentiate by observing the other elements that are seen in conjunction with the crystals. Also, a urine containing radiographic dye will have a very high specific gravity if it's measured on a refractometer. Okay, next we're getting into some of the crystals that are associated with liver disease. Which means that you would rarely see these except in cases of liver disease. The first one is bilirubin crystals, seen in hepatic disorders that produce large amounts of bilirubin in the urine. They will appear as yellow, clumped needles or granules, and a positive chemical test for bilirubin should accompany the presence of the crystals. Viral hepatitis or other disorders that produce renal tubular damage can produce crystals that are incorporated into the matrix of casts. Tyrosine crystals are seen as colorless to yellow fine needles that can be in clumps or rosettes. They will commonly be seen in conjunction with leucine crystals as well as positive result for bilirubin. In addition to liver disorders, they're also associated with inherited disorders of amino acid metabolism, which we're going to go more into in the final unit. And leucine crystals are seen less frequently than tyrosine crystals, though they can also have that yellow to yellow-brown color. They will appear in spheres of concentric circles and radial striations, so they're referred to as wagon wheels. They will also correlate with a positive bilirubin result and will be accompanied by tyrosine crystals when they are present. Okay, iatrogenic crystals, again, that just means pertaining to a condition caused by medication, treatment, or some type of diagnostic procedure. Your sulfonamide crystals used to be commonly seen in patients being treated for UTIs, but that's not as common anymore because more soluble forms of the sulfonamide drugs have been developed. The most common cause of sulfonamide crystallization is due to inadequate patient hydration, and the presence of these crystals in fresh urine can suggest tubular damage. There's a variety of morphological forms of sulfonamide crystals, and that's just because there are so many types of sulfonamide drugs on the market. Some of the more frequently seen forms are needles, rhombics, whetstones, what are referred to as sheaves of wheat, and rosettes with colors ranging from colorless to yellow-brown. Ampicillin crystals can be seen in patients who have received large doses of this antibiotic without proper hydration. They can be colorless needles that can form bundles after being refrigerated. And then radiographic dye crystals. So like we said before, they can be confused with cholesterol crystals, but a specimen with radiographic dye present would also have a very high specific gravity when tested with a refractometer. And then finally, we're going to look at some artifacts that can be seen. So these elements can be confused with actual clinically significant elements, so it's important to know how to be able to tell them apart. The most frequently seen artifacts are starch, oil droplets, air bubbles, pollen granules, fibers, and fecal material. Most are going to be highly refractile and will most of the time be in a different plane on the microscope than the actual urinary constituents. Starch granules, so this could be cornstarch granules. They're highly refractile spheres, usually with a dimpled center that can be confused with fat droplets and can produce a Maltese cross when polarized. Rarely confused with red cells. These are often differentiated from pathologic elements through consideration of other urine chemical results, such as the presence of a positive reagent strip result for blood or protein, and the presence of oval fat bodies or fatty casts. Oil droplets also are very highly refractile. They can sometimes be confused with red cells, but they come from contamination with immersion oils or lotions. Air bubbles, also highly refractile. They can sometimes resemble red cells. These are just the result of bubbles forming under a cover slip. Pollen grains are considered seasonal contaminants. They'll appear as spheres with quote unquote a cell wall, occasionally seen with concentric circles. They are usually going to be large, which will be an indication that they are not a true urinary element because they will be in a different plane than the true elements. Hairs or fibers can be contamination from clothing and diapers. They can be confused with casts sometimes, though they're usually going to be much longer and much more refractile than a cast. Polarization can help to differentiate because fibers will usually polarize, whereas casts will not, except for fatty casts. And then finally, fecal contamination. This is mostly going to be from improperly collected specimens. It can appear as plant or meat fibers or as brown amorphous material in lots of different shapes and sizes. And just a couple different examples here. So these both look like fibers. I'm not sure what this is, if that's supposed to be fecal contamination. Oh, it says diaper fiber. So all of those are artifacts. So again, you would want to just kind of focus in and out to make sure you're in the right plane. Most of these artifacts are going to be much more highly refractile than the actual elements. And then also correlation with your chemical results. That is the end of the lecture for Unit 3.